Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, we're going to talk about orbital compartment syndrome, how to decompress it, a better method. I've done lateral canthotomy and cantholysis, I think 5 times in my career, and it's doable, and it's blind. That's the thing. That's the thing you don't understand from whatever sim lab training or visualization you've done in cow eyes or whatever. It's a blind procedure. It's just like a crike. As soon as you make that first cut for the canthotomy, you will lose your landmarks for the cantholysis. So you have to be willing to cut blind. And that's always tough. You can get the job done, but it's not easy. There's a better way. That's what we're going to talk about today with our guest, Julia Elpers, who is an oculoplastic surgeon. She has published on and teaches a better way to do this for emergency folk, probably even for ophthalmology folk. But before we get to that really rapidly, the Resus Leadership Academy, that is our fellowship in resuscitation that you could do within your own home without leaving your job. I have offered regular resuscitation fellowships. 1 year, you have to leave wherever you're at. You come to us, you get paid a fellow's salary, and it's amazing. We've trained and graduated some of the best people out there. But there is a way to do it without having to leave your current job while still staying with your family and not having to come to somewhere else geographically and get near to the same amount of exposure to the ideas of resuscitation. Now, this is for emergency doctors, it's for hospitalists, it's for pre-hospital folks, anyone who wants a comprehensive education in the first 24 hours of acute critical care. And you will be exposed to a curriculum. You will meet monthly with some of the best professors out there in resuscitative medicine. You'll meet with me monthly for a group hangout. We'll hit cases, we'll talk about questions. And it's pretty friggin' great. So if you're interested, if that sounds good, come to Resus Leadership Academy. All one word, Resus, R-E-S-U-S, leadershipacademy.com. And check it out. You'll get some more information and you can see if this is right for you. So resusleadershipacademy.com, resusleadershipacademy.com. Okay, let's get into the show on the vertical lid split method for orbital decompression. So tell us who you are and what you do.
I'm Julia Elpers. I'm an oculoplastic surgeon. I work in Cincinnati and in Northern Kentucky. Yeah, so oculoplastic surgery is basically plastic surgery with regards to the eye and the orbit. That's what I do all day.
Perfect. You're the perfect guest for us because what I wanted to talk about is decompression of orbital compartment syndrome. And you wrote a paper. We'll get to that shortly. So you're just the ideal person to speak to. I guess the first question is, you have a patient with mid-face trauma. You're concerned, you suspect an orbital fracture. What would be the indications to actually do a decompression?
First and foremost, you'd want to take the intraocular pressure. Pretty much every ER should have a tono pen. The key with that is it's so hard when the eyelids are swollen to not put on their eye. So I tell residents and people to try to really pull those lids and feel the orbital bone and then hold that skin to the bone if you need to use your hand to open the eye. If you can not use your hand and the patient's really great and they keep their eye open, that's ideal, but that rarely happens, especially in the ER. And yeah, if it was actually a fracture, if you already knew that somehow, although I'm sure we'll talk about how if you suspect it, you shouldn't wait to get imaging. But let's say you happen to already have imaging, maybe they were transfer or something, and you know that fracture, that's actually a great thing because that decompresses the orbit in and of itself because it allows the blood to go to the sinus. Orbital compartment syndrome really happens when they get that blunt trauma, but they don't get a fracture. Orbital blowout fracture is actually like a safety mechanism in the orbit. To get that fracture just medial to the nerve is most common, and that immediately decompresses the orbit so that the eye is safer. So it's when you don't get that fracture that it's really dangerous, actually.
That's a great tip. Okay, so you mentioned intraocular pressure. What would be a cutoff for you that, like, I don't care about anything else, this is too high, they need a decompression versus, all right, maybe we'll be able to wait and see if opto could come in. So what's your number?
I would say probably 40 or higher, high 30s too. It depends on how confident you are in that measurement, because it's so common, again, in the ER to have an artificially high measurement just because they're usually swollen. It's hard to get the pressure, so you might be pushing on their eye a little bit. I would say always check the pressure on the other side because that way you have that comparison in the fellow eye. But yeah, I would say definitely 40 or higher and they look swollen, then I would be very concerned and I would probably go ahead and cut them. Again, because it's so easy for us, I'm sure we'll talk more about this, but it's so easy for us to fix any kind of cut. Like, that's fine. We can't fix this vision loss. It's like a stroke to the eye.
No doubt. Now, would you have any cutoff for a lower intraocular pressure if there were vision changes or other auxiliary signs like
that's a
APD, et
great
cetera?
question. Yeah, I would say if the fellow eye had a pressure of 12 and then you measure this eye and it's 30, then I would be concerned. Normal is up to 21 for intraocular pressure. But yes, a big difference, I'd say more than 4 or 5 millimeters could be significant, especially if they're having vision changes.
All right. Now, it's not uncommon, unfortunately, for an ED to think their tono pen's working. They only stock one. They go to look at it. It's either missing or trashed. What would you use as clinical signs to indicate the necessity of this? Things like proptosis, things like afferent pupillary defect. What would be the things outside of intraocular pressure?
Yes. So definitely decreased vision. Of course, that can be from so many things, from just swelling or corneal abrasion or something, but also like significant pain with eye movement. And then an APD, yes, is perfect. I have found that a lot of specialties outside of ophthalmology, even like neurology, not that I'm dissing neurology, but it's if you aren't checking it all day, every day, it's a nuanced thing to check. You basically want to see that the involved eye is dilating a little bit when you swing back to it on that swinging flashlight test. But young people, they have a lot of what's called hippus, where their pupil bounces, and so it can be really hard to check. My favorite way to check to see if there's any early optic nerve compromise is actually to do a red saturation test. So just get something bright red folder, or red. We always have dilating drops, which happen to have a red top, which is convenient. But anything, even a red screen on your phone, have them cover one eye, look at that red, cover the other eye. If the involved eye appears less red, we don't care if it's blurry, that's fine. We want to know, is it more desaturated? So is it more gray? Is it not as vibrant? Is the saturation not as strong? If that were true, and then you could even check it a few minutes later, same with pressure. I would say doing serial measurements is always helpful, because if they have a bleed, the pressure should keep increasing, that vision should keep getting worse. And so that could be a great indicator. Okay, I think I should have a little bit heightened level of concern here.
That's fantastic. I never heard of that, so that's super cool.
So what I do for like thyroid eye disease also. There's the most common thing that will come to the ER, of course, is trauma. You could have a bad thyroid patient that's getting orbital compartment syndrome from that. You could also have a really bad orbital cellulitis. I've had to we sound very cool and we call it a cut down. I've had to do cut down on the occasional orbital cellulitis too, even like kiddos. It's not just trauma.
Gotcha. All right. In the show notes for this episode, I will put information on the red saturation test, the test for afferent pupillary defect, but also the POCUS test for afferent pupillary defect, which is markedly superior, I think, because you don't need to open up the eye. And it's super easy and it's super good. And I think it's what you should be doing on this ocular trauma, because it's so much better than trying to shine a light in an eye that you're prying open. So check all that out. Now, you mentioned imaging. Sometimes the patient's so sick they wind up going to get their CT scans before they've had their secondary survey, and they might have missed their significant eye injury. And now you see a big retrobulbar hemorrhage on the CT. What would make you, on CT scan results alone, say this patient needs a decompression, or is there nothing? Do you then still need to measure the intraocular pressure?
I would say there's nothing on imaging that would, I think that if it's something you happen to have, I think that's a great red flag of, oh shoot, I really need to check this person's pressure and see what's happening in this orbit. But I wouldn't say there's something specific on the scan that makes me be like, oh, this person needs to be cut, without even looking at them. One thing that can help a little bit on imaging is, even if they have a fracture, their sinus can fill with blood and they can still get orbital compartment syndrome. It'd be more rare when you have a fracture, because again, that decompresses the orbit. But if the sinus is filled with blood, I wouldn't say a fracture rules out syndrome. So that's something else I would look for, to see just how much blood's in their sinus.
Now, I preach and practice aggressive resuscitative medicine. So if I have an indication, I'm going to do this procedure. In fact, I'm looking for opportunities so I could teach. A lot of people in EM, on the other hand, they would like to avoid it if they could. They'll do it if forced, but they would rather not perform these kind of procedures. What would be a time course if you've identified an elevated intraocular pressure, that ophtho is on their way, that you would say it's not horrible to wait? I've heard bandied
Right.
around 2 hours. That doesn't ever make sense to me when I see those kind of things.
Yeah.
I'd get petrified to wait 2 hours on this. But what if it was 15 minutes? So what would be, do you think, a reasonable accommodation for ophtho coming in?
I mean, it would be miraculous if they got to the ER so fast that it's okay to wait for ophtho. I mean, obviously, we did a lot of these procedures when we were training at a level in trauma center. And so they would wait for us a lot. But I think it's a little bit variable depending on when their injury happened.
Hey, folks, we're just going to stop for a second because this is a free episode. I'm giving it to you in its entirety, but it's very rare that we have these full free episodes because EMCrit is a members-only site that still has foam. But if you're enjoying this content, please consider becoming an EMCrit team member. It's inexpensive. You get CME. You could write it off on your taxes, but forget all that. What it's going to do is make you the best possible resuscitation and critical care doctor you could be. You'll have the most cutting-edge, up-to-date information, and you'll get it in the comfort of your car or on the subway or while running, and you'll never have to think, am I current enough or not? Am I taking the best care of my critically ill patients? All right, let's get back to the show.
Because their injury happened an hour ago, I really don't think you should wait. If they live in a big city and they got there quickly and it happened like a half an hour ago, could you wait 15 minutes? Yeah. I wouldn't wait an hour though. Studies say it's between 60 and 120 minutes that you lose vision. It's basically should be thought of as a stroke, and time is vision really. And so in my opinion, unless it's like you have ophtho in-house or they are a quick call away, I really wouldn't wait. And unfortunately, we did have some people in training that got transferred to U of L, where I trained in Louisville, prior to cutting them, which we definitely have people who lost vision and we didn't get it back. Now, I have had people where I've cut them hour and a half, 2 hours after their injury, and they do regain some vision, but I still wouldn't cling to that. I would say it is so worth it to just, even if it's going to be messy. It's never clean when ophtho's doing it. It's a friggin' mess. It's okay. We can fix any mess, but we can't get that vision back.
There you go. All right, let's talk about how we'd actually do this decompression. What brought you to my attention is you had published one of the only papers doing experimental analysis of a new procedure, which you folks called vertical lid split. And I've also seen it referred to in the literature as the Paracanthal one snip method. You guys were doing 2 snips, so the one snip method wouldn't be a good name. Vertical lid split. And this, when I saw it, because I had trained in lateral canthotomy and cantholysis, that's what I've done for my orbital decompressions. I've never enjoyed it, but it was a workable procedure. I saw this and I'm like, oh my gosh, this is brilliant. If this works, this is so much better. So tell us about how you got involved in studying this and where you found out about it, and we'll go from there.
Yeah, so let's see. So the person who pioneered the study was Roxana Fu. She was a fellow when I was a resident, when I was in my transitional year at Indiana University. And so she had started this cadaveric study with orbital pressure. So she was measuring not only intraocular pressure with a tonopin, but also intraorbital pressure with like a manometer thing. Anyways, and she had actually, one of my friends from med school who also was doing that same transitional year with me, started doing the study.
Super cool. All right, let's talk about the actual procedure. So maybe just give us a broad overview and then we'll go into intricate detail about each step. So what are we actually doing here?
We are just releasing the tight eyelids from the bone. So with a true canthotomy and cantholysis, what you're doing is making a canthotomy, which I really harp on this. A canthotomy does nothing to reduce the pressure. It's literally just your entrance. You've just made a space in the skin to where you can get to the superior and inferior lateral canthal tendon. It's like a Y-shaped tendon that comes from your lateral orbital rim and connects to the upper lid and the lower lid. And so when you do a canthotomy cantholysis, you can cut one or both of those tendons. Unless it was a mild call, I've almost always cut both because you might as well. Again, we can fix anything down the road, but you got to release that pressure as fast as you can and as much as you can. And so with the vertical lid split, it basically avoids that need of knowing that anatomy of the tendon release. Now, knowing the anatomy, that's straightforward. I just told you it. You could look at a picture and you'd get it. What's really the hard thing about the traditional gold standard canthotomy cantholysis is that it's by feel. Because you do that canthotomy, their orbit is already filled with blood. It is so tight. So even if you like practice on a cadaver It is not the same as a person where you are prying their lids apart. You're wondering, are you going to cut the conjunctiva? Also, if you do, it'll be okay. That'll heal. But basically, you've made that canthotomy, so your entrance wound, and then everything's bleeding. Some blood's being released. Also, you just cut into a very angry lateral canthus, and so it starts bleeding. So then you're working under a puddle of blood. And so totally by seal, then you grab that lateral edge of the eyelid, you strum with your scissors. I usually use like a straight iris scissor. You could use a Stevens, tenotomy, whatever you have in the ER is fine. Grab that lateral eyelid margin and you strum for that lateral carpal tendon. And that's really where I feel like it is difficult if you don't do it all the time to feel that tendon. And so you strum, you cut it, and you really want to get a big release of that lid so it's released from the bone. And I would say most commonly when I've been coaching like ER residents doing it, they're hesitant to get that full release because they just don't know what it feels like. They've never done it before. And you're working under a pool of blood, so you can't see anything. And I think that's a very not natural thing to cut into somebody's face, let alone next to their eye, where you can't see what you're doing. And so the vertical lid split is just so much easier. You basically are just causing marginal laceration, which you'd normally call opto for, and you're just creating it. Instead of them coming in with an injury, you're making the injury, but you're saving their vision. And so you just go a little bit away from the lateral canthal angle. I think in the paper we say 3 or 4 millimeters. If you go further or not as far, it's totally fine. And basically just stick that scissor with one arm under the lid and cut. I'd say cut almost a centimeter or even a little more. Again, even if you cut the levator muscle, it's fine. Like we will fix it later, and it tends to heal really well. I've fixed some very destroyed eyelids and gotten great function back. And so a very controlled one cut is so easy for us to fix down the road. And so basically with that vertical lid split, you're cutting through the tarsal plate, which in the top eyelid is 10 millimeters. In the bottom eyelid is about maybe 4, sometimes 6, depending on the person. And so you're cutting through that. And then when you get a little bit above or below that in the respective eyelid, you're cutting a little bit of the septum too. But basically those tendons that we're talking about in the lateral canthal tendon, those are hanging on to tarsus. So instead of cutting them, you're just going a little further over, you're cutting tarsus. But you don't have to do anything blind. You can just cut the lid vertically and you'll get a great release, which that's basically what the paper was proving, is that it's just as good as the gold standard canthotomy canthalisis.
All right, in just a second, I'm going to take you through step-by-step the procedure and we'll go over any tips and tricks. But why did it take... Now is this emerging and the other method was dominant for decades when this just seems a billion times easier? What was the missing link that was not being seen here?
That's a great question. I guess I can't say for sure. I think maybe the fact that marginal laceration has always felt like a big deal in the ER, the fact you have to call for that, and maybe the idea of creating it yourself sounds stressful or harmful. But yeah, and I think that maybe people thought that canthotomy and cantholysis would just be easier to teach, or maybe they always assumed that ophtho would be available because so many academic papers are coming out of level 1 trauma institutions. But that's so unrealistic. There's not ophthalmology in rural areas almost ever. And yeah, I think maybe over time, the recognition that more people were losing vision than necessary, and that they did a bunch of surveys that I think I referenced in the paper about, just like you were saying, that some ER physicians don't feel comfortable doing this, would like to wait for ophtho or maybe transfer the patient. I think that's especially true in a rural area because maybe this kind of big trauma doesn't come in all the time. So I don't know if it was maybe some of those surveyed papers that kind of brought it to light, but yeah, it should have been sooner, honestly, because this is an approach that to the eye socket that sometimes we use just in a controlled surgical setting. It's reasonable to cut the lid sometimes to get where you need to go in the orbit. And again, it's just so easy for us to fix those lacerations.
Let's take you through the procedure here. Are we actually cleaning this with betadine or chlorhexidine? I know I don't want that on the eye. In real life, are we just using some saline or are you actually using real stuff?
Say in real life, it's pretty messy. I definitely never had a set up sterile procedure. I know sometimes when it was caught early, some of the residents, when I was a senior, some of them would...
Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now. 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Ask for them to, at UL called room 9, to take them to whatever that main room is where you bring big traumas or big strokes or whatever. And sometimes they would even get sedated with propofol for this, which sounds dreamy, but I never did that. I think that's a waste of time unless you know that it just happened and you have a little bit of time. It's honestly something gonna hurt the patient, even if you try to numb it, which of course, I'm not that mean. I did try to numb it. Just when you're doing that, I would say point away from the eye because they might jump on you and then you could end up stabbing their eyeball, which is not ideal. And yeah, I was almost always doing it at bedside, whatever ER room they were in. I did not always use, I would say I use alcohol at least, but I would numb up their eye because they're going to feel that conjunctiva side. And so that can help some.
Let's go through that. So I was using 1 cc of lidocaine with epi for the lateral canthotomy. What are you doing for? Seemingly, for me, the lower lid seems easy to anesthetize. The upper lid, I don't know. That seems scary. I might just be making that cut.
Same. I know. The lower lid, it's usually not quite as swollen and crazy looking as the upper lid. So I could see how that seems easier. But yeah, basically I would just use, if you're being very nice, you can use a 30 gauge needle, but using something smaller, like a 25 or 27 is fine. Injecting cc or 2 in that lid, I would say, yeah, you don't want to inject like 5 cc's because then you're adding more pressure. But really, if you just get it right under the skin, close to the lashes, again, pointing away from the eyeball, it's going to numb up that whole thing as good as it can. Now, when you have Compartment syndrome, everything's a little messy. And so I would say the numbing doesn't work quite as well as it does like in a controlled operating room. But yeah, I would say just injecting maybe a half to 1 cc in the top and bottom eyelid should do it. And I wouldn't expect it to be completely numb. I would expect to need some extra people in the room holding the patient still and coaching them like, hey, this is going to hurt, but it's necessary to prevent you going blind.
All right. Now, there's some folks in the literature that are talking about this same method with 1 snip. And they're just doing the lower lid. In your study, I think the only study that's actually evaluated the efficacy of this, albeit on cadavers, you guys were using both the upper and lower lid. Do you recommend cutting the lower and rechecking? Do you recommend just doing both? What's your stance on this now?
I, like you, am aggressive when it comes to this kind of treatment and emergent situation. So I would generally go for both. But if it was like a soft call, like you were like, oh, their pressure's in the 30s, but it is way higher than the other side and they have some vision symptoms, then I would maybe consider just doing the lower lid and then rechecking. But again, just because it's pretty easy for us to fix those lacerations, I would just do it. I would just do both. I can't remember the exact percentage, but I think in the paper I even talked about some percentage. I can't remember if it was like a quarter maybe of patients with orbital compartment syndrome that required both, that had inadequate pressure relief from just one. Now, I think that was about superior and inferior canthalisis, but still, yeah, I would probably just go ahead and do both because, again, it's just, you're not going to do something that we can't fix.
My experience is if you were to just do, for instance, the inferior canthalisis, and I assume it's the same thing, just doing the lower lid, it takes a couple minutes for the intraocular pressure to stop dropping. Do you actually have a number in mind at which point you'd recheck and say, this is as best I'm going to get from whatever I just did?
I usually recheck, I'd say, at about 5 minutes and then maybe again at 10 minutes. If at 5 minutes it hasn't changed at all, I'd probably go ahead and do the opposite lid.
If people are scared enough that they're just like, if I have to do this, I'm just doing one if I could get away with it.
Yeah.
What drop in their intraocular pressure would make you say, yep, you're out of harm's way until ophtho arrives? Or you're not looking probably for normal, but what kind of drop would you want? Let's say they were at 40 when you did this.
I generally would want them to be in the 20s.
Okay.
Regardless of what their starting was.
Good.
If their starting was 60, maybe I'd be okay with 30. But it really should come down nicely once you have those lids released.
Will there be ophthalmologists that come in and say, what the hell did you just do? You were supposed to do a lateral canthotomy and cantholysis. What is this? Why you cut in the wrong place, you idiot? And you can tell them all you want. No, the intraocular pressure is better. This is the new technique. Will there be people that never heard of this and think that you're an idiot if you did it?
Okay, I hope that nobody would think you're an idiot. I hope they would say, whatever you had to do, I'm glad you did it. But yeah, I'm sure there are people that don't know about this. I think most of these papers are either in the kind of main OPRS, the Ophthalmic Plastic Reconstructive Surgery Journal, or I think my paper was in Orbit. It's a very specialized field. So do things from our literature make it into emergency medicine literature or even general ophthalmology literature? I wouldn't say that's for sure. But you can always refer them to the paper or to me. Say, Dr. Elpers told me.
All right. At this stage of the game, is there still an indication to train EM residents and trauma docs in lateral canthotomy and cantholysis? Or if you had your druthers, would they just train in this?
I would say it'd be great to train them in both. You could maybe show them what the gold standard is, but then let them know, but hey, that seems hard. Let's do this easier thing. Because somebody might come out of training, go to a rural area, and not do this again for 10 years. And so trying to remember exactly what they saw or experienced when they were trying to strum that lateral campal tendon, I would say that's probably pretty tough. Even some ophthalmology residents probably, or ophthalmologists probably wouldn't feel comfortable 10 years out doing this. Just the other day, one of our glaucoma specialists was asking me how to do it because when we do retrobulbar blocks, like before some cataract surgery, glaucoma surgery, all kinds of eye surgery, there's a risk of intraorbital hemorrhage. And if you haven't done it in years, it can be intimidating. And so, yeah, I think it would probably be ideal to let all EM residents know that this is an option. And it's great if they want to learn the traditional technique and if they've done it successfully. And then if they go to level 1 center and they end up doing this more often, that's great. But I think all EM residents should be trained in the vertical lid split because honestly, you don't even really need much training. There's nothing to feel. You just need to know where, just grab that lid and cut it.
Absolutely. Would there be any contraindications to this? If the patient's vision's at risk, even if they're on a DOAC or an anticoagulant, I think this still has to be done. Is there any contraindications you can think of?
No, I would say if you're confident they have compartment syndrome, it'd be much worse to have them lose vision than to have them bleed. There was one time in training where we ended up having to take someone to the operating room because he wouldn't stop bleeding. We just couldn't control it in the ER. But again, he didn't go blind.
Yeah,
so that's ideal.
Is there anything, Dr. Elpers, I should have asked you that I didn't?
Not that I can think of. It's pretty straightforward, really. It's accessible to anyone with forceps and scissors. And so I think it's straightforward enough to where people should just try it if they don't have ophtho readily available.
I can't thank you enough. You are a superstar. You're the perfect person to have interviewed for this. So thank you for your time.
Thank you so much for having me. This is fun.
All right, folks, there you go. The vertical lid method for releasing orbital compartment syndrome. I think this is markedly easier than the lateral canthotomy cantholysis. I think this is what you should be training in. This is what you should be doing. I don't even know if you need to sim it. I mean, it's like, you get it, right? Like I tell you it in words and you get it versus the canthotomy cantholysis. So I think this is what you should be doing. But I'm curious to hear what you think. So put it in the comments for this episode. Remember, Resus Leadership Academy, resusleadershipacademy.com if you want to get more information about doing a resuscitation fellowship without having to leave your current situation. This has been Scott Weingart for the EMCrit podcast saying bye-bye.